and in today's video, I will be discussing the chapter 2 of your ICD-10 chapter specific guidelines 2020. So we're done with chapter 1, so we're moving on to your chapter 2. And after this video, I will be discussing the chapters 3, 4, 5, and 6. So hang on there. Keep watching the other videos that I have, like the introduction to your ICD-10-CM, the general coding guidelines, the chapter 1, part 1, and part 2, because those are very important things before moving on to your chapter 2, neoplasm. So based on my experience, a lot of questions are coming in through your chapter 2 chapter specific coding guidelines, which is your neoplasms. Okay, so stay tuned, keep watching. Let's move on to our chapter 2 neoplasms. Okay, so before moving on to the chapter's guideline for your neoplasm, let's start first with the general guidelines under the chapter 2 neoplasm. So your chapter 2 of the ICD-10-CM contains the codes for most benign and all malignant neoplasms. So remember, when we say neoplasm, it doesn't mean that it is always a malignant. Neoplasms can be benign or can be malignant. So most of the time, most coder, most students taken that when they hear the word neoplasm, they mean malignancy. It's not. So when we are talking about neoplasm, it can be benign or it can be malignant. So it's very important for the providers to always designate or to always document what type of neoplasm is it. Is it benign or is it malignant neoplasm? So certain benign neoplasms such as prostatic adenomas may be found in the specific body system chapters. That's why it tells you like most benign, because other benign neoplasms can be found in the other chapter or in other body system chapters. So remember, our ICD-10-CM guidelines, chapter specific is up to chapter 21. Other chapters are divided based on the specific body system. Okay, so like for example, are we talking about the pulmonary system? Are we talking about the diseases of the cardiovascular systems, like that? So the guideline is telling us that not all benign neoplasms is in chapter 2, because other benign neoplasm can be found in the other body system chapters. Now, I hope that you watch the introduction to your ICD-10-CM, because I mentioned there that when we are coding neoplasm, we need to have or we need to use the table of neoplasm. So to properly code your neoplasm, it is necessary to determine from the record if the neoplasm is benign, is it in situ, is it malignant, or is it uncertain, or is it unspecified at all? So you can find these terms or this word in your table of neoplasm. When you go to my video on my discussion about the alphabetic index, I discussed on how to use your table of neoplasm. Because when we are coding neoplasm, we need to know the anatomy first, followed by these terms. You need to know these terms like benign, in situ, malignant, and uncertain and unspecified in order for you to properly code a neoplasm. So I'll show you the table of neoplasm that I have here. So when you encounter codes like the physician documents benign neoplasm, the physician documents your malignant neoplasm, it is very important to look at the table of neoplasm. Your table of neoplasm, you can find it in the book in your alphabetic index, the gray one, the first part of your book. Because you need to know first, when you are coding neoplasm, you need to know first your anatomy. Okay, because your codes in neoplasm are divided based on your anatomical location. So as you can see in this first column that I have here, we are talking about the anatomy. So when we're talking about the abdomen cavity, the abdominal cavity, any organ in the abdomen, or abdominal viscera. Okay, so we have abdominal wall, or as your neoplasm, abdominal wall or skin, connective tissue, skin, basal cell carcinoma, abdominopelvic, and accessory sinus. So it is alphabetically arranged. Not it in your table of neoplasm, it is alphabetically arranged, not cephalocaudal. But it is divided based on your anatomical location, and it is alphabetically arranged. Okay, so when you're good with your anatomy, and in the exam or in the scenario, they will always mention the specific location, the anatomical location most of the time. Because you need to know that in order to code for your, to properly code for any neoplasm. Okay, the next thing that you need to know as per your general guideline, you need to know if it's benign, in situ, malignant, or uncertain, and we have an additional which is your unspecified. Okay, so when we say malignant primary, okay, so you need to know if it's malignant. Okay, so when we're talking about cancerous, cancer, or positive malignancy, or the documentation is telling you that it is really a cancerous one or a cancer one. So it is divided in if it's the primary or malignant secondary. When we say primary malignancy, it is the origin of the cancer. Like when you have your lung cancer, your lung cancer started really in the lungs. Okay, but if your lung cancer metastasizes or it involves the other organs, like for example, your cancer metastasized to your, or spread out, that's the layman's term for that. It is spread out to your other body areas or to your any organ that is near the lungs. Like for example, it metastasized to the liver, or it's your lung cancer spread out to the liver. Now you may suffer now your liver cancer. So you may have both, like you have your lung cancer, which is your primary, and you may also have your liver cancer wherein the lung cancer spread out to the liver cancer. So what is your primary cancer there? Your primary malignancy is your lungs. Okay, primary malignancy of the lungs. And your metastasis or your malignant secondary is your malignancy in the liver. So when you call what you call the cancer in the liver is what we call the secondary malignancy of the liver. We are telling it that it is a secondary because the reason why there is a liver cancer, it's because of your lung cancer. Okay, next column is your carcinoma in situ. When you say carcinoma in situ, there's like a tumor. It is a cancerous one, but it is capsulated, so it doesn't spread out. It is a cancerous one, but it is capsulated. It doesn't spread out. Stay there. So remember your encapsulated tumor most of the time is a characteristics of a benign, okay, tumor or benign neoplasm. Okay, so they will always mention if it's a carcinoma in situ in the documentations. They need to specify that because we cannot assume. Okay, your benign is obviously it's not cancerous. It is capsulated and it can be removed. Okay, and how will you determine if it is a malignant or benign? Of course, it runs through pathologic studies, any pathology reports like that. Okay, when you say uncertain, they try to do an examination. They try to examine what type of neoplasm the patients may have, but unfortunately, they were not able to identify if it's a benign or if it's a malignant one. So you need to have a documentation of the provider that it is really uncertain. Okay, so they will always mention that it is clinically uncertain or clinically undetermined. That is your basis before you will going to use your uncertain. Next, the unspecified. Most of the time, the unspecified is there is already confirmation of malignancy, like, or if there's also confirmation of benign neoplasm. Unfortunately, they weren't able to specify what type. Remember this one. When you go to your example here, when you go to your skin, under your skin, you have three different types. You have your basal cell carcinoma, specified type, and squamous cell carcinoma. Well, for example, so there's a separate code for that. What if the doctor documents only abdominal skin cancer, malignant cancer of the abdominal wall, or malignant cancer or malignant neoplasm of the skin of the abdomen? So they did not specify what type of neoplasm in the documentation. So that's the time you will going to use your unspecified. Okay? Your unspecified behavior. It's certain, like when you use your uncertain, there's a documentation or clinically undetermined or clinically clinically uncertain, versus your unspecified. It's based on the documentation. There's no documentation at all what type of neoplasm is. So you may end up using your unspecified, or you may query the provider if possible. Okay? Next, primary malignant. Now let's go to the specific guidelines. We're done with your general guidelines of your neoplasm. Let's move on to your chapter specific guidelines of your chapter 2. Or we're still talking about the general. I'm sorry for that. We're still talking about the general guidelines before moving on to your primary. Okay. As I mentioned that most of your all of your neoplasm codes are divided based on your anatomy. What if a primary malignant neoplasm that overlaps two or more contagious next to each other's sites should be classified to the subcategory of 08? Because remember, there are certain conditions wherein, like for example, there is a carcinoma or skin cancer which overlaps the nose and the mouth. Okay, so there's a specific code for skin of the nose versus the skin of the cheek, like for example on the cheeks and in the nose, and it overlaps two or more sites, and if there's a specific code for that. So if there's an overlapping lesion, we have an additional code, or we have an option subcategory, which is your subcategory 0.8, unless the combination is specifically indexed elsewhere. Okay? For multiple neoplasm of the same site that are not contagious, so if it's not contagious, you need to code them separately, because remember, there are different codes for each anatomical site. Okay? Next one, general guideline, malignant neoplasm of ectopic tissue. When we say ectopic tissue, a common example here is your pancreas. Okay? Remember your pancreas, it is in the digestive system, obviously. And a portion of it is outside the stomach, but a portion of it is inside the stomach. Okay? So, what if the patient suffered your ectopic pancreatic malignancy involving the stomach? Now, you may now suffer a stomach cancer, and you may now suffer a pancreatic cancer because a portion of that pancreas, it is located inside the stomach. Okay. Now, your stomach may also suffer cancer or malignancy. Now, the problem there is a cancer in the pancreas. There's also a cancer in the stomach. So it involves the two anatomical location already. So if it is an ectopic, okay, you may always need to code it to the site of origin mentioned where that neoplasm starts. So if it really starts from the pancreas, you need to code it under pancreas neoplasm or malignant neoplasm of your pancreas. Okay? Okay, So we're done with your general guidelines of your neoplasm. Let's move on to your chapter specific coding guidelines of your chapter 2. Okay, so we're discussing most of the time about the sequencing. That's why I mentioned in my earlier and I've been mentioning this a while ago as we start discussing the chapter 2 that most question came in to your chapter 2 coding specific guidelines of your ICD-10-CM because they will always test you guys how well are you in the guidelines specifically with malignancy. And the very important thing there is you need to know the guidelines in order for you to sequence properly the codes. Okay? If the treatment is directed at the malignancy, remember the general or the principal guideline or the first listed diagnosis most of the time is the reason for encounter. Okay, so keep in mind that your first listed or principal diagnosis in general should be the first listed code should be the reason for encounter. But there are some exemptions, and those exemptions you can find it throughout your guidelines. Okay, now here's the first guideline. If the treatment is directed at the malignancy, designates the malignancy as the principal diagnosis. Obviously, if it's if it's the reason for encounter is the treatment of your malignancy, your first code obviously should be the malignancy. The only exemption to this guideline is if a patient admission encounter is solely for the administration of chemotherapy, immunotherapy, external beam radiation therapy, assigned the appropriate Z51. Remember guys, the treatment of your malignancy is mostly chemotherapy, immunotherapy, and external beam radiation therapy. And the code for those is under category Z51. Like for example, if the patient availed the chemotherapy or radiation therapy or immunotherapy, there's a specific sessions for that. Like for example, it's 15 sessions, 20 sessions, like that, 30 sessions. And what if the reason for encounter is only for the scheduled sessions? If the reason for encounter is solely for the chemotherapy or the immunotherapy session, your first code should be Z51. Okay. That is different from the first one. If the reason for encounter is although the reason for encounter here is for the treatment of the malignancy, but if it states that it's solely for the administration of chemo, immune, and external beam radiation, use your Z51. Okay, this is just an exemption. We will be discussing this one and further as we discuss with the chapter 2. Treatment of secondary sites. Remember, when we are talking about malignancy, there is really a tendency that it may spread out to the other body parts. So it's very important to always check in the documentations if there's already a metastasis. As I mentioned, when you say metastasis, is the spread out of the cancer. So when a patient is admitted because of primary neoplasm with metastasis, and the treatment is directed toward the secondary site only, the secondary neoplasm is designated as the principal diagnosis even though the primary malignancy is still present. Okay, keep in mind that when we are coding, when the scenario indicates a primary and a secondary malignancy, you need to always have two codes. Every time you see a documentation that there's already a secondary malignancy, you always need to code also for the primary malignancy to fully capture what is happening. Okay, now the problem there is what should be the first listed code. Now, as per the guideline, if the reason for encounter is the secondary site, only you need to code first the secondary site. Remember, because that is the reason for encounter. And you also need to code for the primary malignancy regardless if it is still present or regardless if it is already healed or completed with the treatment. you still need to code for the primary. But the first listed code should be the secondary, because there are cases like that the primary malignancy is already treated, but there's still your secondary malignancy, and they are treating now for the secondary malignancy only. Okay, you still need to code for the primary, but the first listed code should be the secondary. If it's your primary is already healed or treated, you may always use your Z codes. Okay, history of your primary malignancy. But keep in mind, a common mistake most of the time, keep in mind that you always need to code for the primary and the secondary, or depending on the reason for encounter. The first list that should be depending on the reason for encounter. So what if they don't mention any primary malignancy? We have a code for that. If the primary site is unknown, we have a code for that, but still need to have two codes. Okay? Coding and sequencing of complications. As I always mention, when you hear the word complications, first listed code should always be complications. Because you need to state the reason why. What's the case of the patient now? What's the condition of the patient now? Okay, but there's an exemption, which is a special guideline that I've been mentioning for number 1. But in this chapter, in your letter C, we are coding this and sequencing the complications. Remember, when we are coding, when we have your malignancy, there are different treatments or different management of your neoplasm. And most of the time, there is your complications. We will always encounter that as we go to the treatment of your neoplasm. So, coding and sequencing of neoplasm associated with the malignancies or with the therapy thereof are subject to the following guidelines. So, number 1, please put a note, put a star, put a highlight. Anemia associated with malignancy. So, what I mean by associated, the patient suffered anemia due to malignancy. The common example here is like, for example, you have a cancer of the bone, or your cancer of the kidney, that there is decreased production of your RBC or your red blood cells that may be associated to your anemia. So if it's stated in the scenario that the anemia is associated to malignancy, your guideline is, remember my guideline a while ago, the principle or the first listed diagnosis should always be the reason for encounter. But this is an exemption to this guideline. So that's why I called it as the special guideline. When admission and encounter is for the management of anemia associated with the malignancy. Remember, the reason for encounter is anemia. The treatment is only for anemia. The appropriate code for the malignancy is sequenced as the principal or first listed, followed by the anemia. So it's a contrary with our, it's an opposite of our guideline, that the first listed should always be the reason for encounter. This is an exemption. Okay, if the anemia is associated to malignancy, even if the reason for encounter is for anemia only, you need to code first malignancy followed by your anemia. Okay, so anyway, when you go to your D63.0, they will tell you that you need to code first for the neoplasm. There is an instructional note in your tabular list rather. There is an instructional note there that you always need to go to your you need to code first for your neoplasm followed by your anemia. Okay? Anemia associated with chemotherapy or immunotherapy. Now, if the reason for encounter is the patient may suffer. Remember, when there is a chemotherapy or immunotherapy, the common complication there is the patient may suffer anemia. So, if there's an anemia associated with chemotherapy or immunotherapy, only treatment is for anemia, code for the anemia, followed by neoplasm, and followed by your T45-1X5. If it's an adverse effect, it is usually an adverse effect. Okay? The anemia is most of the time the adverse effect of your immunotherapy or your chemotherapy. So if the reason for that anemia is due to chemo or immunotherapy, code for anemia. So we're back to the normal guidelines. But if it's anemia associated to malignancy, code first malignancy. But if the anemia is due to chemotherapy or immunotherapy, you need to code first for your anemia, followed by neoplasm, and your adverse effect of your immunotherapy or your chemotherapy. Anemia associated with the radiotherapy, anemia, neoplasm, anemia first, neoplasm, and your adverse effect of your radiation beam radiotherapy. Okay. Number 3 guideline. Management of dehydration due to the malignancy. Like, for example, the patient is scheduled for chemotherapy, but before performing the chemotherapy, the physician determined that the patient is in dehydration or it's in radiation therapy. It is a common complication of if your chemotherapy and your immunotherapy is your dehydration. Now, if the physician managed first the dehydration, okay, before doing anything, before any treatment or management of your malignancy, you need to code first for the dehydration followed by the malignancy. Okay, so the additional guideline here is the first listed code should always be the reason for encounter or the first focus of treatment. Or the focus of treatment or the reason for encounter. Okay? Treatment of complications resulting from surgical procedure. We're talking about complication. Again, your first code should be your complication. As I always mention, every time you see the word a complication, the first code should always be the complication code. When the admission encounters for the treatment of the complication resulting from a surgical procedure, designate the complication as the principal or first listed if the treatment is directed at resolving the complications. Okay? Primary malignancy previously exists. So if there's no further treatment directed to the site, no evidence of any existing primary malignancy, you may now use your history. Z85 Personal history of your malignant neoplasm. Okay, Z85 Personal history of your malignant neoplasms. Extension, invasion, or metastasis. What if there's an extension, invasion, or metastasis, or what we call your secondary malignancy? If it's still present, you need to code for the secondary malignancy followed by your history. As I mentioned a while ago, that when you have your primary and secondary malignancy, you always need to code them both. Code first the reason for encounter or the focus of treatment. Okay? Admission encounter involving chemotherapy, immunotherapy, and radiation therapy. So, the episode of care involves surgical removal of the neoplasm, and it's followed by your chemotherapy. Obviously, the first listed code is your malignancy because that is the focus of your treatment. Okay? And if there's, it's followed by chemotherapy, you may use your chemotherapy code, radiation code, which is your Z51. But if the reason for encounter is solely for chemotherapy, you need to use first the Z51. Okay? Patient admissions encounters solely for administration of chemotherapy, immunotherapy, and external beam radiation therapy. As I mentioned, if the reason for encounter is solely for administration of chemotherapy, you need to code first your Z51. Okay? And it should always be followed by a malignancy code because you need to specify why they are performing chemotherapy, immunotherapy, and radiation therapy. Okay? But you always need to check if that is really the sole reason for encounter. If it's really the sole reason for encounter, you need to code the Z51 first. This is a common question in the exam, so keep in mind. Okay. If the patient admission is insertion of your implantation of your radioactive elements. Remember before performing any radiation external beam therapy, they always need to put in the radioactive elements first. If that is the reason for encounter, you cannot code. The appropriate code for malignancy is sequence as the principal code. And you should not be assigning the Z51 because you are not yet performing the radioactive therapy. Okay? Same thing when a patient is admitted for a purpose of insertion and it develops complication. Any condition that develops should always be a secondary cause. And the reason for encounter should be your malignancy. I mean, in general, any condition that develops during the admission or develops only, there is a reason for encounter. So if that means the reason for encounter should always be sequenced first. Okay? Admission encounter to determine the extent of malignancy. Remember, when we are talking about malignancy, we have your stages. Stage 1, stage 2, stage 3, and you have your stage 4 cancers. When the reason for admission encounter is to determine the extent of the malignancy, or for a procedure such as paracentesis or thoracentesis, the primary malignancy or appropriate metastatic site is designated as the principal or first diagnosis, even though chemotherapy, radiotherapy is your administered. Because when we are talking about, you are going to determine the extent of malignancy, we're talking about the malignancy, so your first code should be the malignancy. Okay? That is your guideline. Symptoms and sign abnormal finding listed in Chapter 18 associated with neoplasm. Your Chapter 18, guys, is your symptoms, signs, and ill-defined conditions. And the guidelines here is your you cannot replace a code for signs and symptoms to any malignancy code. Okay, so that's the guideline here. Secondary site malignancy cannot be used to replace the principal or first listed diagnosis, regardless of the number of admissions or encounters for treatment and care for the neoplasm. Admission for encounter for pain management, we will be discussing that in your Chapter 6. Okay? Malignancy in 2 or more non-contagious sites. As per your general guidelines a while ago, if it's a non-contagious site, you need to code them separately for different site. A patient may have more than one malignant tumor in same organ. So here, like for example, there are multiple tumors in the kidney. Okay? So these tumors may represent different primaries or metastatic diseases depending on the site. Okay, it can be you have 3 tumors in the kidney, but they have different site or different reason or different representations. So should the documentation be unclear, the provider should be queried as the status of each tumor so that the correct codes can be assigned. So you need to have a separate code for each tumor depending on what type of tumor they have. If it's malignant, the other one is carcinoma in situ, the other one is benign, or the other one is uncertain. Okay? Disseminated malignant neoplasm unspecified. When we are talking about disseminated, just highlight C80.0. When we are talking about C80.0, we are not able to identify the sites, the primary or secondary sites. So in this guideline, is used only in those cases where the patient has advanced metastatic disease and no known primary or secondary sites are specified. So for example, there is your secondary malignancy, but we don't know what is your primary yet. So you may use your C80.0. Okay? It should not be used in place of assigning codes for the primary site and all known secondary sites. Here's your malignancy neoplasm without specification of site. Here, guys, there is a documentation that they cannot. Okay, the patient had advanced disease and no known primary or secondary sites as are specified. In your C80.1, we are talking about unspecified. They are not mentioning any site. They just mentioned cancer. Okay, cancer of the esophagus. Remember, there are different parts of your esophagus. They need to specify that. This code should only be used when no determination can be made as the primary site of malignancy. Okay, so guys, every time you encounter a secondary malignancy, treatment of secondary malignancy, and they did not specify any primary code for a primary site for malignancy, you need to use your C80.1. This code should rarely be used in the inpatient setting. So it's rarely that you can find it in the inpatient setting, but most of the time you can find this in your questions in your exam. Now, if you don't find, like for example, the patient came in for the treatment of a secondary cancer and they did not specify any primary cancer, so you may end up using C80.1 because, as I mentioned a while ago, you always need to have 2 codes when you have your secondary malignancy documented in this scenario. Okay? Sequencing of neoplasm codes. So this is very important. Put a star, keep in mind, okay, put your heart here because in the exam, they will always ask about the sequencing. Okay, so number one sequencing guideline, if the encounter is for primary and there's also a secondary, of course, the reason for encounter is the primary, code first primary, followed by your secondary. Encounter for treatment of secondary malignancy, obviously, if the reason for encounter is for secondary, code first your secondary, followed by primary. As you can see, there's always two codes for them. Okay? What if the primary malignancy site is not specified? You need to use your C80.1. Malignant neoplasm in pregnant patients. When talking about pregnant patients, you always need to code first your O codes. 098.1 followed by malignancy. Regardless, your code for malignancy will still follow the sequencing depending on the guidelines for malignancy. But for pregnant, you always need to code first 098.1. Okay? Encounter for complication associated with neoplasm. Again, when we are talking about complication, code first for the complication of neoplasm, followed by neoplasm. Exception is for your anemia because your anemia associated to malignancy. Code first malignancy, followed by your anemia. Okay? Complication for surgical procedure for treatment of a neoplasm. Again, when an encounter is treatment for the complication resulting for a surgical treatment, the complication should always be the first listed code. Okay. Pathologic fracture due to neoplasm, it case-to-case basing depending on the reason for encounter or the focus of treatment. Now, when I say pathologic fracture, this your fracture or your the fracture is associated or due to any underlying conditions. It's not traumatic. So the opposite here is your traumatic fracture versus your pathologic fracture. So now focus of treatments is on the fracture. Should be your pathologic fracture should be sequenced first, followed by neoplasm. Now, if the focus of treatment is neoplasm and the patient also may suffering a pathologic fracture, code first for neoplasm, followed by your fracture. Okay, current malignancy versus personal history of malignancy. Now, it's very important in your coding, guys. I always see this when I'm auditing codings, that it's very important to determine if the primary cancer is still present or not, because this may impact the reimbursement. Okay? So, a malignancy is coded in the primary diagnosis for as long as the treatment is directed to the malignancy. If there is still an ongoing treatment for the malignancy, you can code the primary diagnosis as the malignancy. Once the treatment has been completed and there's no further treatment directed to the site and there's no evidence of any existing primary malignancy, that's the time you use your Z85 or your personal history of your malignancy. So, we're talking about current versus personal history. So, it's very important that you can find any evidence in the documentation that there's an existing versus the treatment has been completed already. Okay? Leukemia, multiple myeloma, and malignant plasma cell neoplasm in remission versus personal history. The categories for leukemia and category C90, multiple myeloma, and malignant plasma cell neoplasm have codes indicating whether or not the leukemia has achieved remission. When you say a remission, this is your reduction or disappearance of the condition. It is really different with your cured already, treated already, because there are cases like there's a remission or there's a disappearance of the signs and symptoms, but the leukemia is still present. So we have an options for that. We have a separate code for leukemia and multiple myeloma that is already achieved remission. Okay, there are also code for personal history. So if the document is unclear as to whether the leukemia has achieved remission versus your history already, you always need to query your provider. Okay, the last one I think for your chapter 2, malignant neoplasm associated with transplanted organ. This is a very, very unfortunate situation that the patient receive a transplanted organ, but that transplanted organ suffered neoplasm. So like for example, there is your transplant of your kidney and that transplanted kidney suffered neoplasm. So your reason for that, like for example, is no longer your kidney dysfunction, but it's already the cancer. So every time you hear the word complication, you need to code first for the complication. And as another tip,
Most of the time, codes for complications starts with letter T under the T codes. Okay, so sequencing T86 dash followed by C80.2 malignant neoplasm associated with transplanted organ, and then specific malignancy. It's very important you need to copy this beside your guidelines. Guys, all of the sequencing that I've been mentioning in my slide, you may write it right beside the guidelines so that you don't need to read the guidelines in the exam anymore. Because you can see the sequencing there. That will really help you in the exam. You can answer that in just 10 seconds, 20 seconds, okay, in the exam. Okay, you can do that. Okay, so I think this is the end of your chapter 2, and in our next session, we will be discussing chapter 3, chapter 4, and chapter 5, and chapter 6. So hang on, guys. We are moving on to your chapters 3, 4, 5, and 6. So we're done with 1 and 2. Moving on to your chapter 3, 4, 5, and 6. Hopefully everyone is safe. Happy coding, guys. And if you are new to my channel, don't forget to hit the subscribe button, hit the notification bell so that you will be notified every time I have my upload. So I know, guys, a lot of you are studying now the CPT. Once I'm done with coding I'm done discussing the ICD-10-CM 2020, I will definitely discuss right away the CPT, and I think this will help a lot of you guys. So thank you. Please share this video. If you like this video, don't forget to share, like, and subscribe to my channel. Thank you and keep safe.